Good Wednesday. It is 12:02, March 19th. A beautiful day that the Lord has made outside. If you guys have been out, it's exceptional today. So we're excited to get started. And probably the greatest committee in the House this year is the Health Subcommittee. So welcome you guys all out in the audience. We have a full committee today. Let's sign in first, if you guys don't mind. Madam Clerk, will you please take the roll? Madam Clerk, take the roll.
Mr. Chairman, you have 6 members present. You have a quorum.
Thank you, Madam Chair. Any personal orders from the committee today? Not seeing any before us. We do have a very, very full, busy calendar on our final calendar portion today. Let's take care of a few housekeeping orders if we don't mind. We've got item number 3996 is being rolled to the heel. Each time. Yep. Item number 1141 is being rolled to the heel. House Bill 865, item number 10.
Item 10, HJR.
Oh, sorry. Yeah, House JR 122 will be rolled to the heel. Item number 13638 by Carringer is rolled to the heel. Item 14644 by Carringer is rolled to the heel. Item 1349 by Littleton has been rolled to the heel. Item 1351 by Littleton's rolled to the heel. Item 1046 by Hale is moved to first calendar of 26. Item number 22, House Bill 32 has been taken off notice, and House Bill 1102 has been also taken off notice. With that, we are back to the beginning of the calendar, and we have House Bill 510 by Chairman Terry. Get a motion. Motion in a second. Chairman, you are recognized. I do believe you have an amendment with us.
Yes, Amendment 5501.
Motion. Second. Second on amendment. All in favor say aye. Opposed, no. The ayes have it. Chairman, you are properly before us.
All right. Thank you, Chairman Committee. And I do want to say, normally I would not have my bills at the first of our calendar, but in a couple of weeks, in a couple of weeks, I may have some conflicts with my schedule. And so hopefully we can get these taken care of. So the AMA has projected that the U.S. is facing between a 37,000 and 124,000 physician shortage by 2034. And the American Association of American Medical Colleges has echoed these projections, estimating that we're facing around a 90,000 physician shortage by roughly the same time period. So what this bill aims to do is acknowledge the physician shortage problem and have the Department of Health compile information relative to the physician shortage and provide it to us for use in policy decisions such that we can better address the physician shortage for our patients. So the bill directs the Tennessee Department of Health to reach out to Tennessee physician organizations with a series of issues related to recruiting and retaining physicians. And the organizations will be the ones compiling the information from physicians to submit back to the Tennessee Department of Health. And Tennessee Department of Health will provide this to the House and Senate chairman, health chairman, for the preliminary information at the end of 2025 and a final report at the end of 2026. And the Department of Health has expressed they can do that with existing resources.
Thank you, Chairman. Any questions or comments to the sponsor? Not seeing any. Madam Clerk, please open the vote. All those in favor of House Bill 510, vote aye. All those opposed, press no. Madam Clerk, please take the vote.
Mr. Chairman, 6 ayes, 0 nays.
The ayes have it. House Bill 510 moves on to health full. Moving right along, House Bill 203 from Chairman Terry has been motioned. Second.
Thank you.
And you have amendment, I believe.
4649.
That is correct. Motion second. All those in favor say aye. Aye. Opposed? No. The ayes have it. We are properly before us, Chairman. You are recognized.
Thank you. And in keeping in line with these surveys from first bill, this is essentially a similar bill. And amendment requires the Board of Nursing to develop a survey that collects certain information from nurse practitioners who have been issued a certificate of fitness by the board and have that information submitted back to us.
Question has been called. Madam Clerk, please open the vote. All those in favor of House Bill 203, press aye. Opposed, press no. As all members voted, any members wish to change their vote? Not seeing any. Madam Clerk, please take the vote.
Mr. Chairman, 7 ayes, 0 nays.
The ayes have it. House Bill 203 moves on to health full.
Thank you, Chairman Committee.
And for those watching along, we will move around a little bit today in the calendar. We have some folks that have traveled a long way to testify later in the day. But currently, let's move on to number 4, House Bill 1203. Chairman Kumar, you got a motion? Second. There we go. Motion in a second. I can second it too. There we go. And you have an amendment with this bill, correct, sir?
Yes, sir. It is 5152.
Motion, second. All those in favor say aye. Opposed, no. Ayes have it. Chairman, you are properly recognized on the bill.
Thank you, Mr. Chairman and members. We all know that this is a high-stress society, and add to that a high-stress profession, and sadly, substance abuse creeps in once in a while. House Bill 1203 deals with physician who is caught in that situation, but is aware of the situation and chooses to self-report himself that he is caught in this unpleasant problem. No harm has occurred. So this is a physician who is self-reporting about substance abuse. This bill allows that the board, while interviewing the physician in a private executive session, may choose to assign them to a peer assistance program in which they will be closely monitored as to their competence, their ethics, and the professional work that they do. And if they agree to do that, they can continue to practice under the license issued by the board. Failure to maintain their peer review organization monitoring, they are subject, of course, to disciplinary action, and their records that were previously private become public, and they can be reported to the National Practitioners Data Bank. Mr. Chairman and members, I do have with me Dr. Reeves Johnson from Tennessee Medical Foundation, which is our main peer monitoring advocacy group, to answer any questions between me and Dr. Johnson.
Thank you, Chairman. Committee, have any questions for the chairman or for Dr. Johnson? Yep. Yes, sir. Representative McKenzie, you're recognized.
Thank you, Mr. Chair. Not necessarily a question, but a statement. We had earlier conversation about how we're, at having such a shortage. And I guess my words, I really appreciate the process that our physicians go through to obtain their degrees and go through the residency program. And sometimes things happen from mental breakdown, whatever point of view, family situations, and that we need to understand that these are highly skilled, highly trained professionals that may have come into a unfortunate part of their life. So I'm glad that you're bringing this bill. The previous conversation kind of took a turn, so I really appreciate that we're acknowledging that just because someone's had a blip in their life, that we don't have to put a scarlet letter on them, and that as long as they're actively in that recovery program, because it is a lifetime thing, right? It's not just I'm doing good right now. It's a constant effort, and that as long as that person's doing that we're going to allow them to serve their community. So thank you for bringing this bill.
Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chair. I just wanted to thank Dr. Johnson for being our doctor of the day yesterday, taking good care of us. So appreciate you being here looking after us. Thank you.
Any further questions for the sponsor? I appreciate Dr. Johnson's welcome by yesterday, educating me a little bit more on this topic and helping answer some questions in that regard. So thank you for being here. Without further discussion, Madam Clerk, we are ready to vote. If you don't mind opening the vote. All those in favor of House Bill 1203 moving on to full, press aye. All those opposed, no. All members voted. Any members wish to change their vote? Madam Clerk, please take the roll.
Mr. Chairman, 7 ayes, 0 nays.
The ayes have it. House Bill 1203 moves on to health full.
Thank you, Mr. Chairman and committee members.
And you might as well stay there. Chairman Kumar, we've got you for number 5, House Bill 1205. Motion second on the bill. And there is an amendment traveling with it, or amendment on the bill, correct?
Yes, we have 4516.
Let's get that on there first. Motion and second. All those in favor of amendment, say aye. Opposed, no. The ayes have it. You are properly before us, Chairman.
Thank you, Mr. Chairman and committee. House Bill 1205 clarifies the situation regarding physicians prescribing medications for themselves or for their immediate family. This activity is not legally prohibited. There is no law against it. However, caution is needed because these are responsible actions. And according to our ethics, a physician-patient relationship with oneself or with family can be difficult to attain. Professional organizations recognizing this difficulty have issued ethical guidelines, that is, in our case, the AMA and the TMA. There is, however, confusion among general public, especially the media, even my pharmacy colleagues, about when or whether a physician can prescribe for themselves or for their family. This bill uses the ethical guidelines from the AMA and TMA to confirm the conditions in which prescription to self or to family is allowed by a prescriber. In short, a prescriber may prescribe to oneself or to family for short-term, self-limited, minor, or acute emergency situations. A prescriber may, we added this additionally, may also treat family for illnesses within their practice expertise if there is no other physician available to treat them within 30 miles. The situation being, if you're the only doctor in the county, you're treating everybody else's blood pressure, but you can't treat mom. That should not happen. So we added that, and apart from that, controlled substances are, of course, prohibited, except in exceptional acute emergency situation. Thank you, and I'll be happy to take any questions.
Thank you, Chairman. Any questions from the committee for Chairman? Chairman Terry, you're recognized.
Thank you. Appreciate you being before us. So just to clarify, so if, from an emergency situation, I mean, I've got severe asthma and say, you know, going out of town or something, could I, call in an inhaler for me, or can you explain how this would impact that?
Sorry, Chairman Kumar, you're recognized.
Well, thank you. Precisely, or we have a family, we have a daughter in Nashville, and I'm back over there, and she gets a cold, and it's invariably is the weekend or a Thanksgiving holiday, and another physician is difficult to reach, but also at times we don't want to impose on our colleagues. We should be able to prescribe to ourselves, again, short-term, limited situation and urgent situations. Definitely.
Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chairman. Chairman, so on the narcotics, opioids, you said it would be limited emergency, except could you give an example of where that would be possible? Because, I loved your bill until I heard the rural aspect of it, and I think that kind of was defeating the purpose of part of this bill. So what would that limited access be?
You're recognized.
We really have to be careful, and I think it amounts to pretty well a prohibition as far as narcotics are concerned, except in a very acute emergency situation. You're talking about, again, an acute back pain or anything, and over a holiday weekend, a person should be able to get medication without going to the emergency room.
Thank you.
Any further questions for the sponsor? Not seeing any. Madam Clerk? We are ready to vote. All those in favor of House Bill 1205, press aye. All those opposed, vote no. Any member wish to change their vote? All members voted. Madam Clerk, please take the roll or the vote.
Mr. Chairman, 7 ayes, 0 nays.
The ayes have it. House Bill 1205 moves on to healthful. This moves us on to the Chairman Kumar calendar number 6. Just stay right there, friend. This is item number 1201.
Motion.
And a motion and second. And we do have an amendment with the bill, sir. So
Yes, Mr. Chairman, I have 005533.
that is correct. Motion second. All those in favor of adding the amendment on, say aye. Opposed, no. Ayes have it. Chairman Doc Kumar, you are properly before us.
Thank you, Mr. Chairman. House Bill 1201 addresses the well-known problem that doctor appointments are hard to get. We have a physician shortage in the United States as much as of 124,000 physicians. Tennessee alone has a shortage of 6,000 physicians within our state. In 2023 and 24, this legislature passed bills to authorize the Board of Medical Examiners to issue provisional license to international medical graduates, whether U.S. citizens or not, to be given a provisional license to practice for 2 years under supervision of a medical center that has a training program approved by the ACGME. After 2 years of satisfactory work, they are entitled to an unrestricted license. Qualifications included, of course, graduation from a recognized medical school, passage of required exams, including USMLE, the same exam that our US graduates take, job offer from a medical institution, and a legal visa of entry into the United States. While these laws are in place, our yield from this program was not much because we have about less than 15 medical centers in the state of Tennessee that have an improved training program. Well, the states while we were the first in the nation to do this, and there were op-eds written in the New England Journal of Medicine about it. However, the states of Alabama and Florida went farther very quickly, and they opened up the slots where these physicians could be trained and practice in the beginning to many more venues. And I think what this bill does is to catch up with them so we can also take advantage of having more spots where these physicians can be appointed and trained to relieve the physician shortage. These include federally qualified health centers, rural clinics, community health centers, postgraduate training programs, and specialty clinics. But all of these must have a board-certified physician supervisor. And we are not talking collaborator, we are talking supervisor because these people are under training. And after serving 2 years, then they're entitled to an unrestricted license. And again, our hope is that we will be able to bring more physicians to Tennessee. Thank you.
Thank you for that explanation, Chairman Kumar. Representative Mitchell, you're recognized. No. Oh, sorry, McKenzie.
Thank you, Mr. Chair. And, I definitely applaud the desire to get us up to speed in terms of the number and dare I say, quality of physicians that practice in our state. And this is just probably more of a pet peeve, but I think it's valid. After all of these things that you have, all of these qualifications that really get to the point of it, you has sufficient evidence of good moral character. One that's very subjective, and we're talking about folks that are coming into the country, I guess,
Right.
or trying to practice here in our country. What does that look like, and how can we set a standard of what that looks like? I mean, that's one of those. I call it just a weasel word, just to try to throw things out there. But how do we prove that? because it's in law if we keep that.
Chairman, you're recognized.
You're very correct. When we try to set moral standards, they're relative. We don't have absolutes anymore in today's society. It is an effort to say that this person does not have a past record. They have not been convicted or disciplined for any unethical or criminal behavior, God forbid.
Representative McKenzie.
Thank you, Mr. Chair. And I wish you would have said that instead here because, you know, in the days that you're hearkening back to, I may or may not have made that cut. So you know, that's why that type of statement kind of bothers me. So yeah, you know, there's never been a black and white definition of what that looks like. So I just, you know, maybe just words to legal. As we get words like that don't really mean anything and can be used as a barrier, I think we should just say if you want a clean record, say that. But this, you know, good moral character, it's a pendulum that never really gets to whatever I think this is getting at. But thank you for the bill.
Chairman, you're recognized.
I request that we not interpret that phrase according to political standards. Okay.
Chairman Terry, you're recognized. Thank you. Appreciate you explaining this bill to us. So at the end of the process, and they, from the supervision that they have, would this doctor be able to apply for a specialty residency or something along those lines?
Chairman, you're recognized.
Yes, certainly. They would have a regular unrestricted license as a physician in the state of Tennessee. But when it comes to a specialty training, board eligibility, they'll have to go through the process just like everybody else does.
Chairman.
And that, thank you. That's my, I guess, obviously, if this gets passed, I'm gonna have to work. We may have to work our way through that because I'm not sure that the boards, how they, the different residencies, how they address that if they have this type of license. So that may be another bill that we may have to work with. But thank you.
Yeah. Thank you.
Thank you, Chair. Any further questions for the sponsor? Not seeing any. Madam Clerk, mind opening the vote? All those in favor of House Bill 1201, press aye or yes. All those opposed, press no. Madam Clerk, take the vote.
Mr. Chairman, 7 ayes, 0 nays.
The ayes have it. House Bill 1201 moves on to Health 4.
Thank you, Mr. Chairman and committee.
This will move us to item number 8, House Bill 1239 by Madam Chair Helton Haynes. Got a motion and a second.
Thank you, Mr. Chairman.
We have 2 amendments, I believe, with this. Is that correct, Madam?
That's correct. We have 5070 that makes the bill, and then one is just removing a section, which is 5872, a provision.
Let's get a motion in a second on the first.
Okay, let's get a motion and a second on the first one. Motion second. All those in favor say aye. Aye, opposed, no. Ayes have it. And let's move on to item number 2, which is 5872. Motion second. All those in favor say aye. Opposed, no. Ayes have it. And then we will roll those together.
Okay, thank you.
Without objection, we'll roll those together. Now, Madam Chair, you're properly before us.
Thank you, Mr. Chairman. House Bill 1239 as amended creates an exception for mid-level providers to be able to prescribe buprenorphine products for the treatment of opioid use disorder in correctional facilities. This legislation outlines certain restrictions and requirements for them to be able to do so. They must be employed by or contract with a state correctional facility or a county or municipal jail to provide healthcare services. They are only authorized to prescribe buprenorphine products to patients who are treated through the correctional facility that employs the provider. They must be supervised by or collaborate with a physician who reviews 100% of the charts of the patients being prescribed a buprenorphine product and who is limited to the supervision of or collaboration for a maximum of 5 licensed nurse practitioners or physician assistants. They must have adopted clinical protocols for the facilitation or continuance of medication-assisted treatment for persons who are incarcerated in or to be released from such state correctional facility or county or municipal jail. They cannot have any limitations or conditions imposed on the provider's license by the provider's licensing authority within the previous 3 years. They're prohibited from writing any prescription for a buprenorphine product that exceeds a 16 milligram daily equivalent, and they must have an active registration with the federal DEA. And the amendment that just removed a provision was the prescriber to enter into the info into the controlled substance monitoring database. These prescribers likely don't have access to the CSMD, and the pharmacies are already entering the info into the CSMD. This legislation is necessary so that our correctional healthcare providers may treat those within the walls of our prisons and jails for opioid use disorder in a realistic and timely manner. It is not possible to have a physician see and prescribe all those needing this medication, as the numbers are simply too high. And with that, I stand for questions.
Thank you, Madam Chair. Any questions for the sponsor? Not seeing any. Madam Clerk, please open the vote. All those in favor of House Bill 1229, vote aye. All those opposed, vote no. Madam Clerk, please take the vote.
Mr. Chairman, 7 ayes, 0 nays.
The ayes have it. House Bill 1239 moves on to health full.
Thank you, Mr. Chairman and committee.
This will move us on to item number 9, House Bill 466 by Madam Helton Haynes. A motion, second. An amendment is with this, I do believe.
Yes, 4009.
Let's get that on the bill. All those in favor of the amendment, a motion and second. All those in favor of the amendment say aye. Aye, opposed, no. The ayes have it. Madam Chair, you are properly before us.
Thank you, Mr. Chairman. This bill removes the mandatory 30-hour per week requirement for a lab supervisor to be on the premises in the code. Instead, the statute would clarify that a supervisor be readily available for consultations during all hours when tests are performed. Tennessee's statute would remain in line with the federal CLIA guidelines that many other states follow. Current technology and the ability to provide remote monitoring make the requirement overly burdensome on a system that needs capacity. This bill would increase capacity without compromising safety and quality. The amendment just changes the effective date to upon the governor's signature. This should allow for labs to move more quickly to implement the law. And with that, I stand for questions.
Very good. Yeah, Chairman Hill, you're recognized.
Thank you, Mr. Chairman, and thank you, Chair Lady, for bringing this legislation. With your amendment, and forgive me because I just don't have it in front of me, but the amendment that we adopted, does it maintain that section 1 and 2 of the bill, or?
The amendment 4009?
Yes, ma'am.
It just changes the effective date so that the law will go right into effect.
Okay, thank you.
Any further questions for the Madam Chair? Not seeing any. Madam Clerk, please open the vote. All those in favor of House Bill 466, press aye. All those opposed, no. All members voted. Any members wish to change their vote? Not seeing any. Madam Clerk, please take the vote.
Mr. Chairman, 8 ayes, 0 nays.
The ayes have it. House Bill 466 moves on to health full.
Thank you, Mr. Chairman and committee.
Item number 11. Okay, yeah. Item number 11, House Bill 869 by the Chair Lady Rudder. You are before motion. Second. A motion and second. There is an amendment traveling with this bill.
Yes.
Yes, ma'am.
That would be Amendment 3828.
All right. That is what we have. A motion and second. All those in favor of adding the amendment on say aye. Aye. Opposed, no. The ayes have it. Madam, you are properly before us.
Thank you. As amended, this bill changes makes changes to an electronic health record bill that we passed last year. After we passed that bill last year, we had some issues with constituents and their lab results being held up, and some concerns from insurers. This bill is going back to make some changes to fix those unintended consequences. Last year, we passed a law with the right intentions, but inadvertently, lab results for patients across Tennessee. This bill fixes this issue by repealing the 72-hour hold on certain lab tests, and to make sure that Tennesseans receive their lab results in a timely manner without unintended government delays. Tennessee is the only state that requires a 72-hour hold on those test results and on those lab tests. And this unintentionally created bottleneck in lab results for diagnostic companies as they tried to comply to this unique regulation. Last year's bill also required that insurance companies create and maintain an application programming interface, an API, to facilitate patients and providers access to patient information. We required those APIs to be created by July of last year, which was not feasible. So this bill also ensures this requirement for creating those APIs to align with CMS updates of implementation. And I also want to make a notation that Representative or Chairman Vaughn carried this bill last year, and he signed off on this cleanup, and also Senator Reeves in the Senate just passed this out of the Senate yesterday. So with that, I will take your questions.
Thank you for that explanation. Any questions for the sponsor? Not seeing any? No? Madam Clerk, please open the vote. All those in favor of House Bill 869, moving on, press aye. All those opposed, press no. Madam Clerk, please take the vote.
Mr. Chairman, 7 ayes, 0 nays, and 1 present not voting.
The ayes have it. House Bill 869 moves on to Health Full.
Thank you, Mr. Chairman and committee.
Item 12, House Bill 495 by Chairman Baum.
All right, then we'll move on to House Bill number 12, which is item 495 by Chairman Baum. House Bill 495. I believe you get a motion and second. And then we have an amendment with the bill.
Yes, it's Amendment 5156.
That is correct. We'll vote on the amendment first. All those in favor say aye. Aye. Opposed? No, the ayes have it. Chairman, you are properly before us.
Thank you, Chairman Martin. We have patients and their representatives who periodically need to request that patient's medical records. And in some instances, hospitals have contracted that process out to third-party providers. And the result of all this is we have patients that are sometimes charged thousands of dollars for their own medical records. I've got some sample invoices, one that's as high as $12,000. However, in Tennessee code, we have some language that governs how much can be charged for these records. Unfortunately, since that code was written, a lot of these medical records are now being provided electronically, and the code only governs paper copies. With electronic PDFs that are the medical records that can be emailed, there's no postage, there's no Xeroxing. What this bill does is it puts in code caps for electronic versions of the medical records. This bill is the result of an agreement between both sides of the industry, the side that provides the medical records and the representatives of the patients. But the gist of it is that there would be a maximum charge for electronic medical records at $90.
Thank you for that explanation. Chairman Hill, you're recognized.
Thank you. Thank you, Mr. Chairman. Chairman, how did you come to the $90 figure? What led you there?
This was the result of negotiations between The third-party providers in the industry that provide these medical records, companies like Ciox, and the individuals that represent patients, which includes entities like the Tennessee Bar Association and the Tennessee Trial Lawyers Association.
Chairman Hill, you're recognized.
Thank you, Mr. Chairman. Right now in the current situation, when if somebody requests their records and they get them in electronic fashion, what's the cost to them? Is that the out of control cost that you're concerned about? Or what happens right now? What do they have to pay to get it?
Currently in the code, there is a per page fee, and it's kind of graduated, but the highest per page fee is 35 cents per page. But that, I think, contemplates paper records. If you get a PDF with hundreds or thousands of pages of medical records that's just a PDF that's emailed, then there's not actually any Xeroxing going on. There's not actually any postal mailing, no postage. And so what this would do is it would say in the case of electronic records, doesn't really cap it at $90 for paper records, but in the case of electronic records, the cap would be at $90.
Chairman.
And thank you, Chairman. And I'm just trying to make sure I understand it, and thank you for hanging with me. But right now, if someone walks into their provider and they say, I want my records and I want an electronic record of it, they could be charged 35 cents a page, but on the electronic side. Is that correct? Or are we creating a whole new, that's what I'm trying to get at. Are we creating a whole new space of a charge? That's what I'm asking.
We are adding to the code a cap for electronic records. Currently, the code doesn't mention electronic records at all. So the only way you can gauge anything is on a per page basis. It might be 1,200 PDF pages, but that's the number of pages. And you could be charged 35 cents for each one of those pages.
Okay, thank you.
Thank you, Chairman. We do have somebody willing to speak on this on their behalf. So without objection, let's go out of session for a moment. And Mr. John Spraggins, is he in the house? There you go. Come on up, sir. If you don't mind having a seat over there and then introducing your name for the record, and you'll have 2 minutes, sir.
Thank you, Mr. Chairman. My name is John Spraggins, Spragens. I'm an attorney who represents patients who have to obtain their medical records or ask me to obtain their medical records. I don't want to belabor this because I know you all have a busy agenda today, but this bill was the result of negotiations. And one thing I wanted to clarify is that when a patient requests their own records, that's governed by HIPAA, the federal statute, and the high-tech federal law. And there are, certain amounts that they can be charged for their own records. When someone acting on their behalf, like their attorney, requests records, that's where we've gotten into this position that the patient is being charged thousands of dollars potentially. So working with our friends in the hospital sector, we came up with this compromise where we cap it at $90 for electronic medical records. I'm happy to answer any questions. Otherwise, I appreciate the committee's consideration of this bill.
Thank you, sir. Any questions for the speaker? Not seeing any. Thank you again for presenting. We'll go back into back into session without objection. Chairman Leatherwood, you're recognized down there in the end.
Thank you. And had one question here. And some of the material that we have on the amendment, it says it establishes a flat rate of $90. So is it a flat rate or is it a maximum charge? If somebody goes in just wanting a 3-page document electronically?
Yes. The rate would be a maximum of $90. So it could be less, but it would be a maximum of $90.
And just curious, I don't know if legal wants to look, because flat rate is different than a maximum rate.
Mm-hmm.
But here on the amendment paperwork I've got, it says a flat rate. I don't have the full amendment in front of me.
Yeah. Let's go out of session without objection and get legal Department's opinion on that, if you don't mind.
Sure. Heather Asbell, Legal Services. Chairman Leatherwood, I think, you might be referencing the flat rate, the flat fee of $20, which is described for the certification or notary fee for in subdivision A2AI. It references a party such described that requests patient's medical records in paper format. And it says then a certification or notary fee must be charged as a flat fee of $20. So I might be referencing something, another provision.
Yes, I saw that and understand that part, but I think you've got the paperwork next to you now that I was looking at. That it says flat rate $90.
Oh. Yeah, that's talking about the total charges must be no more than $90 for all electronic medical records.
So does language say no more than? Don't want to be picky, but no more than.
Yes.
And flat rate are different. Flat rate, I pay $90 for one sheet.
Mhm. Yes, sir. Yeah. So the language of the bill says no more than $90 flat rate for all electronic medical records.
No, okay, maybe it's just me, but no more than $90 flat rate. Again, I see, does anybody else have a question on this? I just think a flat rate is a flat rate no matter how many pages there are.
That's right. Yes, sir.
I just see that as different than maximum, but maybe I'm the only one. So if anybody else wants to pursue that rabbit, they can. Another question is a charge required?
Chairman, do you have any more for legal? We go back in session.
Nah, I can't think of any
Without objection, let's go back
questions
in.
right off the bat.
Without objection, we are back in session now. Chairman, you may.
Although I could have
Continue.
asked legal, required, or whatever, but I'll point towards you. Is there a required fee? If the provider doesn't want to charge anything at all, is that an option to them?
I'm sure that would be an option. The code does not require any fee to be charged
Okay.
at all. It just seeks to establish a maximum. And I'm probably repeating what's been said, but the bill says no more than $90. And then it does include the phrase flat rate, but I think that's added there because the charges had been on a per page basis. And so it's designed to make it clear that it's not $90 per page or something like that. Since everything had been per page, by flat rate, we mean for everything. But it does say up to. And I probably could add one more thing. Some of you may feel like you've heard this before. We passed almost the exact same bill last year that affected doctors' offices. This is kind of the same bill. It just affects hospitals. All affecting medical records.
Thank you, Chairman. Representative Mitchell, you have a question or comment?
Yeah, thank you, Mr. Chair. And I kind of agree with my colleague from Shelby County. I mean, we're dealing with very learned attorneys in a situation where there's litigation most of the time involved. I'd advise just to have another amendment in full committee clarifying, fixing that situation, because these are very good attorneys in this field, and we don't want any more disputes having to come back and have another piece of legislation. Thanks.
Chairman?
I'm sure the attorneys would be happy to do that. The attorneys in this matter are on the side of wanting to reduce these costs. It's SIOX that would not want the reduction. So I'm sure the attorneys would be happy to draft that language.
Thank you, Chairman. Any further discussion from the sponsor? Or with the sponsor? Not seeing any. Madam Clerk, please open the vote. All those in favor of House Bill 495, vote aye. Those opposed, no. All members voted. Any members wish to change their vote? Madam Clerk, please take the vote.
Mr. Chairman, 7 ayes, 0 nays.
The ayes have it. House Bill 495 moves on to health full.
Thank you, committee.
At this point, none of them are, so we can just call Williams' bill out of order.
But he's not in the room either.
Then let's start going down the list and just rolling stuff.
Okay.
So We'll call it House Bill 960, item 18.
We'll call item number 18, House Bill 960. Without objection, will be rolled to the hill. House Bill 992, without objection, will be rolled to the hill. Item 1049, without objection, will be rolled to the hill. Item 819, without objection, will be rolled to the hill.
There we go.
And we have somebody. There we go. Item number 23, House Bill 387 by Representative Butler.
Freeman's back there. House Bill 387.
House Bill 387, get a motion. Motion and second. All those in, oh, you are properly before us. Do we have a,
I think he does.
oh, there's an amendment. Let me get on the page. There we go. All right. Amendment, you got amendment with the bill?
Yes, sir.
Yes, sir.
Uh,
4188.
88, that is what we have. To add the amendment, all those in favor say aye. Aye. Oh, sorry. A motion. Second on the amendment, all those in favor say aye. Aye, opposed? No. Ayes have it. You are properly before us.
Thank you, Mr. Chairman. This legislation just prevents a medical doctor from asking a patient whether they have a firearm in their home. And this amendment makes some clarifications to some of the folks that we've been working with on this legislation. It exempts all those under Title 33, which are your mental health professionals. It exempts them that have a duty to warn. They are not included in this legislation. Emergency service transport, ambulance, that type of thing, has the ability to ask if you have one on your person. And then finally, if a healthcare provider reasonably believes that a patient may pose a credible actual risk to themselves or others based on information that the patient or person accompanying the patient volunteers, then the healthcare provider may perform a lethality risk assessment. And with that, Mr. Chairman, I'll renew my motion.
Thank you, Chairman. We do have three individuals that would present and would like to speak, if you don't mind. Without objection, we'll go out of order or out of session to allow these individuals to speak. Dr. Kelsey Gastineau, Dr. John Wellens, and Zach Blair. Are any of them here? Please state your name for the record.
Thank you, Mr. Chairman. Zach Blair with Tennessee Hospital Association. First of all, I want to thank Representative Butler for the last several weeks. We've been in a lot of conversation about this particular legislation. The things that we have pointed out that we have concerns is that this applies to any healthcare provider, including the employees and non-healthcare provider facility workers that are in a healthcare facility. As you know, with the rise in violence of healthcare, we continue to face an even more acute issue with folks that are escalated in these settings. And this legislature has also passed a bill that will allow for an enhanced penalty for assault against healthcare workers. Additionally, I do want to let the committee know, and as I've said to Representative Butler, the end effect of this legislation to try to prevent any denial of service because of firearm ownership or the ability to get care, receive payment for care. We do not disagree with that premise whatsoever. In fact, we were hoping that we could arrive at some amendment language that would get us to that position. But as it stands now, all healthcare providers, whether or not they are providing healthcare in a particularly dangerous situation, would have to be prohibited and potentially put their license, facility, or other professional achievements on the line just as a result of asking a question. And then finally, I think the biggest concern from the way the bill is drafted right now, it is the government in state law telling a healthcare practitioner what they can and cannot say. And while we don't have any issue with trying to arrive at the situation where we can prevent discrimination from happening against someone just because they are expressing a constitutional right. The fact that we are taking a blanket approach and not allowing a question to be introduced in any situation is potentially problematic with the situation that we continue to find ourselves in from a healthcare workforce perspective.
Thank you, sir. Any questions?
Chairman.
Oh, thank you. Any questions for Mr. Blair? Not. Oh, Chairman Terry, you're recognized.
Thank you. Thank you for coming to testify. Can you, you brought up the issue about when it says healthcare provider, any employee, assistant, or contractor of such professional establishment or facility. Can you give us some scenarios? I mean, we have what's called a code orange. Can you kind of discuss that and how this might be impactful?
The scenario that, and thank you, Chairman Terry, for that question. The scenario that I think about is someone that were to walk into an emergency department. Obviously, a lot of our facilities are blessed with the resources to be able to provide a significant level of security in certain facilities. However, that is not across the board throughout our state. And I envision a situation where potentially an employee that's in our janitorial staff, or someone that is an armed security guard but not law enforcement, or someone that is a security guard that is not armed but again is not law enforcement. Our understanding of this bill is that would apply to them, and it would apply to the facility itself, and that is the concerning piece, because at that point the intervention in the immediacy could be problematic, but then also following up on the healthcare, whether that be a social worker or someone involved in trying to make sure that there is safe discharge or a safe situation for that patient to go home to, that we would remove that option for discussing that topic in any scenario, except for the mental health exceptions that are currently in the amendment that unfortunately don't cover all of the non-behavioral health things that might end up being behavioral things later on in a treatment situation.
Good. Without further discussion, let's go back into session. Thank you, sir, for your testimony. Chairman or Representative Butler, you're recognized.
Thank you, Mr. Chairman. I just want to clarify a few things. You know, we've worked with numerous parties to come to this amendment that we've got, allowing any medical professional, regardless of their particular profession, whether it's a dentist or a optometrist or so forth, to be able to do a lethality risk assessment. So if a patient exhibited some type of behavior that would lead them to believe that this patient was going to present a threat to themselves or others, they could do a lethality risk assessment. I can't even take credit for that word, but somebody else came up with that. So, but it covers the ability for any medical professional that sees the need to perform that to do that, and to address. He mentioned a social worker on discharge. You know, if they're a licensed social worker, they would be covered under Title 33. So, with that, Mr. Chairman, I renew my motion.
Thank you, sir. Any questions for the sponsor? Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chair. What is the purpose? I'm trying to figure out what are we trying to accomplish by putting another law in the green books? What does this do?
Representative, you're recognized.
Thank you, Mr. Chairman. Well, it was brought to my attention by constituents that were asked this question, do you own a firearm? Well, they were getting a normal MD physical at their primary care physician, which troubled them. And so they left and did not receive the services. They were there at that particular appointment that day. And so this is to prevent them from asking. This is a Second Amendment. This is a constitutional protected right. So there's no bearing whether a person does or doesn't own a firearm to receive treatment.
Representative Mitchell.
I mean, most gun owners I've ever talked to are proud Second Amendment gun owners, and they want to tell you all about their firearms. So I'm really not understanding. You know, they're also asking, you know, are you depressed? Are you in any danger at your home? there's a list of questions that they ask. But these are also, in some instances, they're also the people who, get to try to piece together the baby that grabbed the handgun off the coffee table that no one locked up. They're also the one who, sees the domestic violence victim who's been shot by their spouse. They're also seeing, all the horrendous things that these firearms can do to people. So just asking somebody a question, if they jumped up and ran out of there because of that, I really question, we need to be asking somebody like that the questions. So, I mean, again, we are not doing anything. The number one cause of children's death under the age of 18 in the state of Tennessee is guns. I'm not proud of that. I'm ashamed of that as a Tennessee state representative, and I'd like to continue to try to do something about it, not cause more deaths.
Thank you, Mr. Chairman. If you have an individual that's asked that question, their concern is will I receive treatment if my answer is yes, or will I receive treatment if my answer is I'm not going to answer your question? And so in a rural area, especially something that I represent where there's a limited number of doctors, you could be gravely concerned whether you would receive treatment in the future.
Representative Mitchell, you're recognized.
No, they'll receive treatment. If you want to come down with me on a Friday or Saturday night to Vanderbilt's emergency room where there's going to be a gunshot victim in there Friday or Saturday night, I can assure you they get treated. But we're trying to stop them before they need to treat them in the emergency room in a trauma unit. They're trying to see if something's going on in that person's home, in that person's life, that themselves or someone else could harm them. And these people's lives are on the line as well because they're on the front line trying to piece people back together. And I can assure you there's not a doctor that's taken the Hippocratic Oath that's not going to treat these people. But to put our medical folks in jeopardy, we've just had bills earlier. I had a guy up here saying we need to ship people in from other countries because we can't get enough doctors in this state because we keep running them off. Wonder why we run them off.
Representative McKenzie, you're recognized.
Thank you, Mr. Chair. And just trying to get to like my colleague, to the gist of this bill. So you had a scenario with 7 million people in this state, but you had a constituent say that, did your constituent say that they will refuse treatment because they said yes?
Thank you, Mr. Chairman. Well, I've had several instances that all have called the same issue. They were concerned that whether they would receive treatment in the future or not, to answer your question.
Representative.
Thank you, Mr. Chair. So no one was refused treatment. In fact, they take an oath. They go through a lot of training. They go through a lot of, they're a small business. Mm-hmm. And that's one thing a lot of people don't know. The doctor's office is a small business. So they have a lot at stake. And they have even more rural communities, to your point, where they know they're the only thing there. They have a lot at stake. And so let's call it 20. So 20 out of 7 million people came to you and said that they were asked a question and they were offended by the question, is what they're saying. So we need to get rid of that. They're asked the question, have you had sexual contact with a person of your same sex in the last 3 years? They ask questions, do you have a communicable disease that could eat off of your hand? And do you have AIDS? Do you have a code? They're asked some really horrible questions in terms of what a public cordial conversation would be. But you're not concerned about those because in your mind, that's health related. But they also ask, how are you doing today?
Representative, you're
Well,
recognized.
let me address all the things that you mentioned in your list are not constitutional rights. This is a constitutional right outlined by our forefathers to ensure that we protected these rights. So we're not dealing with all of the things that you're talking about. We're dealing with a constitutional right.
Representative McKenzie.
Thank you. Again, but to my first point, they have a constitutional right. And maybe I'll go out of session and ask this question. Do you mind if I go ask a question, ask the question, and I'll tell you the question. Does every citizen of our state and country have a constitutional right not to be asked if they have a weapon?
Let's pause for a moment. Let's go out of session without objection and ask that Representative McKenzie.
Thank you. You want me to?
Yeah.
So to legal, could you answer me this question? Does every citizen have a constitutional right not to be asked if they have a weapon or not?
Heather Asbell, Legal Services. Everyone has a right to bear arms. And then there's also the First Amendment that plays into here about freedom of speech. And so your question might be better answered by a court for certain, but everyone has a right to bear arms. And then also there's a freedom of speech that interplays with that as well.
Representative Mitchell, or sorry, McKenzie.
Thank you. So to what you just said, so does that constitutional right to speech extends to a questionnaire and the person receiving questions? The freedom of speech piece?
Could you repeat that one more time, sir? I want to make sure I get it right.
Thank you. So in your answer, you talked about constitutional right to bear arms. That means to have a weapon on your person. That means that's what bear means. So consequent, and then you talked about free speech, which is another constitutional right. Does the person inquiring as to, in this scenario, do you have a weapon? Do they have the freedom of speech to ask the question within our Constitution, are you bearing a weapon?
The freedom of speech applies to the person inquiring as well.
Thank you. Thank you, Mr. Chair.
Mr. Chairman?
Yes.
If you're going to ask about a weapon, then you would need to list every available weapon to that individual. A hammer, a brick, the list goes on.
Hold on. We need to go back in session before we start. Yeah. So without objection, we're back in session. Nope. Oh, you still need the one. Sorry.
Yeah, while we are out of session, I need some clarification from legal on this, because the way I read this bill as it has been amended, the word firearm has been taken out such that a provider can ask about a firearm. They just can't ask about possession of or access to firearm ammunition or firearm accessories.
Heather Asbell, Legal Services. Yes, sir. In subsection B, it says a healthcare provider shall not inquire as to the patient's ownership, possession of, or access to firearm ammunition or firearm accessories.
Thank you.
Yeah. Representative, yes.
Thank you, Mr. Chair. So you're saying that if this bill were to pass, a healthcare provider, staff, whatever, can ask, are you in possession of a firearm? Or do you own a firearm?
This bill would not prohibit that.
Thank you.
Without objection, we're back in session. Chairman Williams, you recognize?
Question on bill.
Question on the bill has been called. Madam Clerk, please open the vote. All those in favor of House Bill 387, vote aye. All those opposed, vote no. All members voting, members wish to change their vote. Madam Clerk, please take the vote.
Mr. Chairman, 6 ayes, 2 nays, 1 present not voting.
The ayes have it. House Bill 387 moves on to Health
Thank you,
4.
Roll 1396.
We're going to roll House Bill 1396 to the heel. And that brings us up to item number
26, House Bill.
Item 26, House Bill 979 by Chairman Williams.
Need a motion.
Need a motion? Second. Chairman Williams, you do have an amendment, I do believe.
I do, Chairman. Drafting Code 5346.
Okay, that is correct. All those in favor of opening a motion in a second? Motion second. All those in favor of Amendment 5346? Aye. All those opposed? No.
Aye.
Ayes have it. Yes, you are properly before us, sir.
Thank you, Chairman. I'm just glad to attach my own amendment. It was fantastic. But first of all, wanted to thank the chairman for his indulgence to be able to do this. We had several people that came and made themselves available to testify if needed on this bill. One of which is very important to me is Dr. Bruce Johnson, who's on the front row there. He's from Cookeville Regional Medical Center and chairman of our board there. We're a private act hospital owned in majority by our citizens of Cookeville, which makes us very unique to most hospitals across the state. But for a little bit of background, this bill, for this bill as amended, for over 50 years, Tennessee law has prohibited anesthesiologists, emergency physicians, pathologists, and radiologists from being able to seek direct employment with hospitals. At the same time, hospitals have been allowed to employ other physician types, such as hospitalists, of which I had the opportunity to have my own experience 2 weeks ago with, which was very interesting. This longstanding restriction has created an imbalance and has left our hospitals, particularly mine in rural Tennessee, unable to fully address the staffing issues associated with being able to provide high quality health care to our communities. I've long expressed concern over this, but in the last 2 weeks, it's become apparently clear, particularly when I live in a rural community, how important it is to have people that are employed by your hospital who care about the community, live in the community, and provide those healthcare services to those in your community instead of having someone who's flown in from Denver or Dallas or Pennsylvania in order to provide care just to maintain a contract with an employer who doesn't even reside in your community. This legislation represents a significant step forward in addressing the severe healthcare shortages in Tennessee, particularly in rural areas, and it will make a tangible difference in the quality of care that our citizens hope to receive. As Tennessee population continues to grow and age, the demands on our healthcare system will only increase, not to mention the shortages in just about every category of healthcare service. This bill, for me, particularly is really important because it's a workforce development bill. It allows for us to be able to employ those people in our hospitals that are, as I said before, are invested in our community and know the citizens which they provide health care for. Just as a quick bill summary, based upon this amendment, which makes the bill, this legislation is strongly supported by numerous healthcare organizations, many of which, like my chairman of the board here and many others, include Tennessee Hospital Association, Tennessee Medical Association, the Tennessee Society of Anesthesiologists, Tennessee Radiological Society, Tennessee American College of Emergency Physicians, and the Tennessee Academy of Anesthesiology Assistants. It's a lot of words and a lot of folks, but I'm thankful for their support. This support for these stakeholders highlights the widespread recognition of the need for reform after 50 years of doing it the same way over and over again. This change will provide hospital in those underserved areas with greater flexibility of staffing, helping them to address critical shortages, improve care, and the delivery of that care to our communities. This will allow these facilities to employ specialists in their fields, and by empowering them to make the necessary adjustments to meet those patients' needs. This legislation also allows hospital employee physicians to work for a specific rural hospital or a children's hospital facility and not the entire system, so that those systems would be under a population cap as it relates to these four practices of medicine, that being 105,000 souls. This means that with a rural hospital in a county under this population limit hires a physician, that employed physician is intended to serve the needs only, let me repeat that, only that community and not another community outside that 105,000. That being said, Chairman and members, I'm happy to attempt to answer any questions that the members might have. I will say One of the discussions is also about anesthesiology assistants. As a part of this bill, it was been several years of discussion about those assistants. The ratios are dramatically lower for anesthesiologists and anesthesiologist assistants than we currently have under the physician CRNA practice. Very difficult for hospitals to find revenue when doing that. But 22 other states allow for AAs to be employed in their communities. And with the shortage that we have, we feel like this might be a good first step towards providing those services in a correct way. With that, Chairman and members, I'm happy to answer any questions you
Great.
hope.
Thank you, Chairman. We do have several that want to speak on this bill, so let's go out of session first, if you guys mind. And let's hear from several different individuals. Ms. Janet Setner, Stephen Finder, Kelly Ray, Dr. Louis Chimney, I'm not sure,
Bruce Johnson.
and Mr. Bruce Johnson. If you'd come forward, y'all can all have a seat on where you might like to be. What we'll do, we had numerous on the list, so we tried to pick out some that we could on each side of the argument. We'll go down the list, name for the record, and then 2 minutes each, if you don't mind. Thank you. We can start over here to my right. We'll start first with you guys.
This one?
Yes, ma'am. Name for the record, and then 2 minutes. Please.
Jan Setner.
Good to go.
Okay. Chairman Martin and members of the committee, my name is Jan Setner, and I'm a certified registered nurse anesthetist, or CRNA, a retired colonel from the United States Air Force Reserve, and the president of the 65,000-member American Association of Nurse Anesthesiology. Thank you for this opportunity today to speak to you in opposition of HB 979. This bill will not improve access to critical anesthesia services for the citizens of Tennessee and risks decreasing access to anesthesia services. No state or federal law requires CRNAs to be medically directed by an anesthesiologist. This bill forces facilities to employ anesthesiologists to comply with the Medicare billing rules for medical direction of up to 4 CRNAs at a time. Medical direction is the most expensive anesthesia delivery model there is. CRNAs practice autonomously in over half of Tennessee counties, most of which are rural. These facilities depend on CRNA-only anesthesia models because anesthesiologists are concentrated in urban areas. This hospital bill mandates that hospitals use an anesthesia model of care that is not best for their bottom line nor reflect reality. CMS reports that there are 669 anesthesiologists in Tennessee and over 2,000 CRNAs in this state. You have 7 anesthesia programs that graduates approximately 190 CRNAs annually, with 2 more programs being established now. It's important to note that when I deployed to Afghanistan, I was the anesthesia element lead over physician anesthesiologists and CRNAs. There we worked together but independent of each other. I further deployed as the sole anesthesia provider at a forward operating base deep in the mountains of Afghanistan, again, without physician oversight. This is how CRNAs are trained in all nurse anesthesia programs, to graduate with the ability to make critical life-saving decisions independently. Licensing anesthesiology assistants will not improve access to care in Tennessee. Unlike CRNAs, AAs are prohibited under federal law from practicing autonomously and must be supervised and directed by a physically present anesthesiologist under the costliest medical direction model. I respectfully request that you oppose
You're good.
979, and I'm happy to answer any questions you may have.
Thank you, ma'am. And thank you for your service to our country as well. I greatly appreciate that. Next. And we'll do the questions at the end, just so you guys know. We can go through that.
Good morning. I'm Stephen Fender.
You're good to go, sir.
Thank you. Thank you, Chairman, members of the committee. As president of the Tennessee Association of Nurse Anesthetists, I'm here to strongly oppose House Bill 979, which threatens Tennessee's anesthesia workforce, limits hospital flexibility, and compromises patient access to safe, cost-effective anesthesia care. This bill mandates an inflexible, costly anesthesia staffing model in hospitals employing an anesthesiologist in counties under 105,000 residents, and introduces anesthesiologist assistants statewide under vague supervision rules that undermine patient safety. The bill mandates that hospitals employing an anesthesiologist use a 1-to-4 medical direction model, the most expensive and inefficient approach, limiting their ability to tailor staffing to patient needs. No other state mandates this model. Hospitals should decide the best care model, not a statute. This mandate also has the effect of reducing CRNAs to the same limited role as AAs, preventing them from practicing to the full scope of their education and training. Instead of expanding care, the bill forces hospitals that hire an anesthesiologist to use an expensive, rigid model, a lose-lose situation for patients, providers, and hospitals. This bill licenses AAs statewide, threatening CRNA practice, as well as our 7 nurse anesthesia education programs and clinical training opportunities. CRNAs and AAs are not interchangeable. AAs require direct anesthesiologist supervision and can only work under a 1-to-4 model. CRNAs are trained for autonomous anesthesia care and serve in all settings, including rural hospitals where anesthesiologists are scarce. According to CMS data, CRNAs provide 93% of direct anesthesia services in Tennessee. In states where AAs have been introduced, CRNA practice has been restricted, reducing patient access to high-quality care. Make no mistake, this bill will not fix anesthesia shortages. Proponents claim House Bill 979 expands anesthesia access, but that's false. AAs cannot practice independently. Where there is no anesthesiologist, there is no AA.
Great finish there. Thank you, sir. Right on time. And we'll move over. Ms. Kelly, are you next? Okay, yep. Name for the record, and then you have 2 minutes.
Hey, my name is Kelly Ray. Good afternoon, Chairman Martin and members of the committee. Thank you for allowing me to speak to you today. I'm a certified anesthesiologist assistant in strong support of HB 979, president of the Tennessee Academy of Anesthesiologist Assistants, and here today to represent the many CAAs from Tennessee that want to return home to our families to work in this great state, as well as others that would love the opportunity to move here. I received my undergraduate degree in biochemistry pre-med in Tennessee at Lee University before attending Emory University School of Medicine to obtain a Master of Medical Science and Anesthesiology degree. The educational path to becoming a CAA includes completing rigorous pre-medical coursework, earning an undergraduate degree, and acquiring acceptance into an independently accredited CAA program. These master's level programs are 24 to 28 months in length, and students receive comprehensive didactic simulation and clinical training necessary to become safe anesthesia providers. Upon graduation, CAAs have completed over 2,000 clinical hours and administered more than 600 anesthetics. These totals are almost identical to that of our CRNA colleagues in their postgraduate anesthesia-specific training. Students must pass a national certification exam administered by an independent certifying organization. CAAs must complete 50 hours of continuing medical education every 2 years, along with a recertification exam every 10 years. CAAs provide safe anesthesia care in some of the leading hospitals in our country, including Emory and the Cleveland Clinic. A 2018 study by Stanford Medical School compared CAAs and CRNAs working in the anesthesia care team and found no significant difference in mortality, length of stay, or spending between the two providers. Centers for Medicare and Medicaid Services defines a non-physician anesthetist as a CRNA or CAA. I've been practicing as a CAA in Georgia for 8 years. Please support HB 979 because CAAs are highly trained providers and ready to move our family.
Thank you, Ms. Kelly. We'll move on. Next would be Doctor. You have to pronounce your last name so I don't mess it up again.
Oh, no problem. It's Louis Chemin.
Chemin. Nowhere close. Thank you, sir.
Oh, that's okay. That's all right. All right. My name is Louis Chemin, and I'm an anesthesiologist and chief of cardiac anesthesia in an independent, non-private equity private practice group. I earned my medical degree from Tulane University and completed my anesthesiology residency and fellowship at Emory University, where I also served as an assistant professor. This bill, House Bill 979, will not alter how anesthesia services are currently provided in hospitals across the state unless a hospital in a rural county or in a freestanding children's hospital in the state wishes to directly employ an anesthesiologist. So suppose a hospital meeting the stated criteria and employs an anesthesiologist and operates under the anesthesia care team model with an anesthesiologist leading a care team comprised of CRNAs or CAAs. In that case, CMS rules regarding medical direction under this bill must apply. These requirements ensure safe and reasonable physician oversight of qualified advanced practice nurses or physician assistants. In non-opt-out states, such as Tennessee, CRNAs must operate under physician oversight. In rural hospitals, this oversight is currently provided by a non-anesthesiologist. The bill permits, but does not require hospitals in counties with fewer than 105,000 residents to employ an anesthesiologist as part of the anesthesia care team model. I have extensive experience in teaching both CRNAs and CAAs. I currently teach CRNAs, taught a lecture just a few days ago at the University of Tennessee, Chattanooga School of Nurse Anesthesia, which gives me a unique perspective on the qualifications and capabilities of these highly skilled professionals. Whether in the classroom or the operating room, I've witnessed firsthand the exceptional expertise that both CRNAs and certified anesthesiologist assistants bring to the table, and I wholeheartedly recommend that certified anesthesiologist assistants be licensed to work in the state of Tennessee.
Thank you, Doctor. And we'll move on to Mr. Johnson. You're recognized.
Yeah, Bruce D.W. Johnson here. I'm a cardiac anesthesiologist in Cookeville, Tennessee. Thank you, Mr. Chairman. Thank you, Representative Williams, for all your work on this. This started out with options for corporate practice of medicine alternatives. We had the issue that we all remember 2 years ago, and we need a different way of employing our new physicians and some of our old seasoned physicians. We are talking to people all the time about employment. Most people want employment now. So this is also about scarcity, which this bill helps us address. Scarcity is the overriding economic factors here. That's what drives the prices, and this helps address that. We were very careful when we were crafting this bill, all the meetings between THA, TMA, the different physician groups, to make sure that nothing has to change when this bill's passed. There's no practice that has to change in this state. Not one, nothing. We don't anticipate a change at our hospital. It gives us options, and that's what we're trying to do.
Thank you, Mr. Johnson. Appreciate that. We'll open it up to questions from anything on those portions of it. Chairman Hill.
Thank you, Mr. Chairman. I guess I'll jump in first. That's normally the guy that gets hurt the most. But just a couple of quick questions, just for the record. It was mentioned over here, and please forgive me, but it was mentioned over here that everybody came to the table and has negotiated this grand compromise. Because you brought that up, were the CRNAs included in the conversation?
No, sir.
Okay. And I think it's fair to say that this very much affects their at the very least, they're concerned about it. And another question to the CRNAs. We have a significant compromise bill that's in front of us. Could you speak specifically to your concern about the medical direction, basically the practice model that's being proposed, and what the major concerns are with this? Because, and then I want to open it up if I can, Chairman. I mean, obviously we've got two sides that are deeply concerned about this issue and are trying to work this thing out. But could you speak to that just very briefly? Because I want the committee and I want to hear, your concern, and then why the bill is in this compromise, why it's written the way that it is. Thank you.
You're recognized, sir.
Thank you, Mr. Chairman. I'm happy to answer your question. Our main concerns are that there's no direct supervision requirements. It's very vague how the language is worded in the bill. There's also no written agreements for AAs to practice, and as a delegated practitioner, we're just relying on that the physician will delegate appropriately to the AA, and they would be the only licensed healthcare provider that I'm aware of that lack any kind of written supervisory agreement or protocol to follow. There's also no patient disclosure requirement, so they're not required to identify themselves as an AA that will be delivering the patient's anesthetic. And in Tennessee, we know that we have some pretty strict naming requirements and disclosure requirements for our patients so that they know who's involved in their care and what kind of care that they're getting. Thank you.
Follow up?
Thank you, Chairman. And I guess I want to understand why from your all's perspective, that, the practice model is the way that it is in the compromise standpoint. Could you just speak to that just very briefly?
You mean the legislation, how we crafted that? Sure.
Yes.
So we crafted it. There are different methodologies of delivering anesthesia. The medical direction model, 4-to-1 model, that's what most anesthesiologists are used to in a training program. So that's standard flow, and that happens all over the state right now in larger cities, metropolitan areas. In my town, in Cookville Regional Medical Center, the cardiac anesthesiologists are MDs. We just independently, we sit in the chair, call it sitting in the chair. And the rest, we have one MD who's there for consultation to help out, to run the board. And the rest is independent practice, or QZ anesthesia is the colloquial term for it. That's the billing term. So again, we're not planning on a change at our place. This just gives us options. But the fear of, I don't see the fear of a medical direction model with anesthesia assistants.
Chairman.
Thank you, Chairman, and thank you for those responses, and thank you all for being here.
Chairman Gant, you're recognized.
Thank you, Chairman. You were just mentioning about the requirements with other states, and it's my understanding that this is a requirement in other states for AA, and PAs in Tennessee are required to have a written agreement here in Tennessee. So why would we not have the same type of requirements for AAs here in Tennessee?
You're recognized.
Thank you, Mr. Chairman. We recommend that we do require them. They should be required for AAs, just like they are for other healthcare providers. In 11 out of 16 states that have AAs licensed, they do operate under a written protocol or a written supervisory agreement. We would be one of the very few states that do not operate that way.
Chairman.
And shifting gears a little bit, can you tell me about the training and educational differences between the two?
Sure, I'd be happy to. The difference is, I know that she has a degree in a science degree, but if you look at the differences in the CRNA world, to apply to a program, you have to have a bachelor's of science in nursing, and the average CRNA has anywhere from 4,000 to 10,000 hours of critical care contact with patients prior to applying to the school. We have a national standard to get into the program. We have a national standard in all 141 programs we have across the country for graduation. To compare to the AA, to our AA colleagues, there is not a specific set of rules. Most recently, we were looking at, let's take Purdue for an example, where it states that you can have any degree that you would like to have, and their school is under the School of Pharmacy, and some schools are under the School of Medicine, and some schools, they don't have a set standard on which school that has to be put under. For CRNAs, we do have a 3-year program with the terminal degree of coming out with the doctoral practice, and our training is to be autonomous. We are trained to make critical life-saving decisions independently, and our CAA colleagues are trained to be dependent and must work under the direct supervision and direction of a physician. So there's stark differences in our training and how we graduate.
Okay, thank you, Chairman.
Without objection, let's go back into session. Thank you guys for your questions and all your comments as well. Any questions for the sponsor? Yes, sir. Chairman Williams.
It's supposed to be on.
Thank you, Chairman. Just to clarify, obviously there's a rulemaking process as it relates to how this bill goes forward. Is the intent of the sponsor and all those involved that the rules will be promulgated just like they would always be promulgated. The ratios are, in fact, and I won't speak for Cookville Regional Medical Center, even though I represent them, but the using the AA model just doesn't make practical sense because the ratios for AAs and anesthesiologists is so low. But really what this does, it gives them two things. One, the ability to recruit and retain doctors that come to rural Tennessee to be able to employ them. Secondly, it allows for them to be able to negotiate better terms that they wouldn't be able to negotiate on a different setting, because our reimbursement rates in rural Tennessee are dramatically different than those of a large regional healthcare center in in Nashville. And so it makes a huge difference. I believe this is going to improve overall quality of care, and more importantly, it's going to add community back to our healthcare systems in those rural areas across the state. Thank you, Chairman.
Yeah, Chairman, myself personally, I'm a big fan of the corporate practice component. I think that's a great concept. But my concern a little bit, as we've discussed and I've discussed with others, is in regards to the CNA component having a voice at the table. So one thing that I'm looking at or collaboratively thinking is, as we move forward, if this deal does move forward, looking at over the next week, potentially some language to clarify or to at least put in writing where some of that area has been concerned. There's some issue with, to the extent of what that might be, and if there's a possibility to work that out, if amendable to you. Thank you, sir.
Yes, Chairman. Obviously, this is a process. There's no way I can know the full impact of all the decisions. I'm happy to look at anything they might have. I did meet with the lobbying firms regarding the CRNAs. There was some discussion. It's not that they've been completely excluded. I think there were just challenges in being able to find something that was tenable for everybody. And those discussions can continue on to full if this committee chooses to move forward with this bill today.
Thank you, Chairman. Chairman Hill, you got a question?
Previous question.
Previous question has been called. That's fine. Without objection, all those, House Bill 979, all those in, Madam Clerk, please open the vote. All those in favor of House Bill 979, vote aye. All those opposed, vote no. Madam Clerk, please take the vote.
Mr. Chairman, 6 ayes, 1 nay, and 2 present not voting.
The ayes have it. House Bill 979 moves on to health full.
We will hear all.
All remaining bills will be taken up next week without objection. We are adjourned.